My original intent was to present primarily a lecture on vitreous, but in order to cover some of the topics that Professor Suzanne Binder was going to cover, I'll be talking about vitreomaculopathies as well. These are my financial disclosures. It's very gratifying for me to see how much emphasis is placed on vitreous, and it's the result of an explosion, really, over the last decades of information that has culminated recently with the publication of a 956-page book on vitreous, and my co-speakers contributed to that book, and if you're not aware of it, I would suggest taking a look at it. Any consideration of vitreous must begin at the biochemical level, because it is 98% water. There are two structural macromolecules of great importance. Hyaluronan renders viscoelasticity, but collagen is the skeleton of the vitreous body. There's an intricate interaction between collagen and hyaluronan, whereby the hyaluronan molecules separate the collagen fibrils by a critical distance to allow the unhindered transmission of photons through the vitreous body to the retina, where vision can begin. We don't really understand this interaction, nor how it changes with aging or disease, but there are structural consequences. Here you can see dark field slit microscopy of a dissected human vitreous body in a 33-week gestational age human embryo, where the anterior segment is below and the posterior pole is above. And there's a homogeneous appearance within the vitreous body, except for the site of Cloquet's canal, the former site of the hyaloid artery during embryogenesis. The reason that there isn't very much light scattering is that the collagen fibrils are separated. This changes throughout life. You can see in the top panel the appearance of the vitreous body in a 6-year-old and in an 11-year-old individual. This is the back surface of the lens illuminated by the slit lamp beam that is creating the horizontal optical section. By middle age, there are fibers that have an antero-posterior orientation. These fibers insert into the vitreous base and are continuous through the vitreous body to insert into the posterior vitreous cortex. By old age, there's been further aggregation of the collagen within the vitreous body with pockets of liquid vitreous called lacunae, and an overall shrinkage of the size of the vitreous body because of posterior vitreous detachment. Ultrastructural correlates of what we just saw by dark field microscopy found no membranes whatsoever, but only bundles of collagen fibrils, such as the one shown here in cross-section. And it was the displacement of the hyaluronan molecules that allowed the collagen fibrils to cross-link and form these large bundles of collagen fibers. This is very exaggerated in old age. As you can see, there are multiple pockets of liquid vitreous with aggregation of the collagen fibrils within the vitreous. This is an important consideration for probably what happens more often than any other event in at least ophthalmology, and that is intravitreal injection. All of the pharmacokinetics and pharmacodynamics of these pharmacotherapies assume that the vitreous is simply a space, but as I hope you appreciate now, it's more than just a space, but it's a body. And it will make a big difference whether an injection of drug is placed into this part of the vitreous as compared to this part, into a lacunae. And it may explain some of the variability from patient to patient and their response to intravitreal injections, but I'm sure you've all had the same experience that any given patient may not respond to one injection on 1 month, but will on another month. And I think that's because we don't control exactly where we inject. It would be challenging to try to introduce control over where exactly drugs are injected into the vitreous, but it is a consideration. This is a transmission electron micrograph of the human Vitreo-Retinal interface. It used to be believed that the vitreous inserted directly into the retina, but we now appreciate that there is an extracellular matrix with these components in it that intervenes between the posterior vitreous cortex and the neural retina. This is an immunohistochemistry preparation by Greg Hageman of the monkey vitreoretinal interface, which further illuminates the structure of the posterior vitreous cortex. It's organized in sheets or lamellae. And this has consequences with respect to not only the pathology of various vitreomaculopathies, but also our surgical approach. And understanding that the underlying anatomy has a lamellar structure is very important. There's strong adhesion of vitreous to the retina in youth, and here too we don't really understand what is the molecular basis of this strong adhesion, but it must relate to some, if not all, of those extracellular matrix components that were considered on the previous slide. Again, without knowing exactly the source of this, we don't understand why, but it's clear that with aging there's weakening at the vitreoretinal interface. Both the liquefaction of the gel that occurs as a result of displacement of hyaluronan with cross-linking of the collagen fibrils within the vitreous body and the weakening of vitreoretinal adhesion underlie posterior vitreous detachment. And it's necessary that both of these occur in tandem in order for the PVD to be innocuous. When you have gel liquefaction without dehiscence at the vitreoretinal interface, an anomalous PVD results. And the manifestation of that anomalous PVD will vary depending upon where the gel is most liquefied and where the posterior vitreous cortex is most firmly adherent to the retina. This schematic diagram demonstrates the various consequences of anomalous PVD. And if you see the different diseases that are listed at the bottom of this schematic diagram, you'll appreciate that in the past these were considered very disparate conditions. But when considered from the context of anomalous posterior vitreous detachment, it becomes a unifying concept to the pathophysiology of these disparate diseases. For when you have liquefaction without dehiscence at the vitreoretinal interface, anomalous PVD can result in full thickness or partial thickness separation of the vitreous. When you have partial thickness separation of the vitreous, the outer layer of the posterior vitreous cortex remains attached to the retina and underlies the formation of a premacular membrane, resulting in macular holes and macular pucker. When you have full thickness separation of the vitreous away from the retina, particularly posteriorly with persistent adhesion peripherally, you can get traction, resultant retinal tears and detachments. And we know that areas of retinal lattice are areas that not only have firm vitreoretinal adhesion, but also a pocket of liquefied vitreous anterior to this zone. Here is a retinal tear that occurred in association with a retinal vessel, another area where the vitreous is firmly adherent to the retina. An anomalous PVD with posterior separation but traction peripherally has resulted in the regmatogenous events. Our main focus today is going to be on anomalous PVD and vitreomaculopathies, where you have full thickness separation in some instances. That means all of the vitreous is separated away from the retina, exerting axial traction in this instance on the macula, inducing a vitreomacular traction syndrome. And this plays an important role in loss of central vision with aging, but also in wet AMD. Here you can see a combined OCT SLO image of anomalous PVD with vitreomacular traction. And I'm indebted to Carl Glittenberg and Suzanne Binder for providing this animation of a patient, which I'm sure many of you who have seen before, but it's a very graphic representation of how anomalous posterior vitreous detachment with full thickness separation of the entire posterior vitreous cortex away from the retina everywhere except in the central macula can exert significant traction upon the central macula with distortions and loss of central vision. It was Suzanne Binder who first brought to my consideration the role of vitreous in AMD, and it was because in the days where she did a lot of submacular surgery to remove choroidal neovascularization, she noticed that a very high percentage of patients had attached vitreous, and these were all older individuals where the vitreous should have been detached. So she asked for my involvement, and I'm very grateful for that, to try to determine whether or not there's a role for vitreous in AMD. And in the first study, we found that there was a twofold higher prevalence of complete PVD in patients with dry AMD. This was diagnosed not only with OCT, but also with ultrasound. And I think ultrasonography is a forgotten diagnostic technology that is very relevant when interested in vitreous and its impact on the retina. The reason being that if you have a posterior vitreous detachment where the posterior vitreous cortex has separated far enough away from the retina, you'll never be able to see that on today's OCT imaging. Perhaps in the future that will be addressed. But to make a diagnosis of a posterior vitreous detachment solely on the basis of OCT is a misleading approach. When looking at patients who did not have a posterior vitreous detachment by ultrasound and using OCT to identify if there was persistent detachment in the macula, we found a threefold higher prevalence of Vitreo-Macular attachment in patients with exudative AMD. And it was felt that partial PVD with persistent Vitreo-Macular adhesion played a significant role as a risk factor for the development of exudative AMD. A follow-up study was done on patients who had one eye wet and the other eye dry in an attempt to eliminate genetic and environmental factors, and we found the same thing, that if your vitreous was detached, the risk of developing exudative AMD was far less than if your vitreous was attached to the macula. And Einar has addressed some of the physiologic considerations, much of which goes beyond the scope of this particular presentation. But recently, we've started seeing studies that demonstrate a role for vitreous in the response to anti-VEGF injections. Suzanne actually presented the first in 2013, where 334 non-responders to anti-VEGF injections in wet AMD were studied, and it was their impression that these were the individuals who had an attached vitreous and that the responders had a detached vitreous. A study done at the Wills Eye Hospital found that in 204 patients with wet AMD, the presence of Vitreo-Macular adhesion increased the need for anti-VEGF injections. That is, they required more anti-VEGF injections than individuals who had a detached vitreous. And then a study done at Moorfields found that a head-to-head comparison of 34 patients with wet AMD who had VMT and 29 patients with wet AMD who did not have Vitreo-Macular traction, those without Vitreo-Macular traction had better visual acuity and less macular thickening following anti-VEGF therapy. So I think the vitreous does play a role in the pathophysiology, but also the therapy of wet AMD. If there is liquefaction of the gel vitreous without separation at the vitreoretinal interface, the typical separation that we see, you can get a split in the posterior vitreous cortex, where the vitreous body separates, but it leaves a layer, the outer layer of the posterior vitreous cortex, attached to the macula. And here we can see, again, a beautiful 3D OCT provided by Carl Glittenberg and Suzanne Binder demonstrating the various lamellae in the posterior vitreous cortex that we saw earlier by immunohistochemistry in the monkey retina. And these are potential cleavage planes, not only during aging or in various diseases, but also during surgery. Swept source OCT is beginning to show us in greater detail the underlying anatomy of the posterior vitreous cortex, and I think you can appreciate here those same lamellae that are potential cleavage planes during aging and posterior vitreous detachment, where the entire vitreous body will separate, but the outer layers can still remain attached to the macula. This is spectral domain OCT demonstrating the inner wall and the outer wall of a patient with vitreoschisis who had macular pucker. We did some studies and found that 42% of eyes with macular pucker had evidence of vitreoschisis, as shown here very dramatically. This is also true of patients with macular hole, where 53% of individuals had a split in the posterior vitreous cortex. Here you can see this is full thickness posterior vitreous, but here is the inner wall and here is the outer wall of the split posterior vitreous cortex. And it's important to appreciate that, because if you only eliminate this traction here, the patient may not get better. The dynamics of these membranes is very different. In macular pucker, there is inward contraction towards the fovea, so-called centripetal tangential traction, throwing the underlying retina into folds, whereas in macular holes, this layer that remains attached to the retina exhibits centrifugal or outward tangential traction. And we believe that the reason for that is that there's a much higher incidence of vitreopapillary adhesion in patients who have macular holes as compared to macular pucker, and that this alters the dynamics of the vectors at play at the vitreoretinal interface and contributes to the outward traction in patients with macular holes. Macular pucker is a condition that induces distortions and blurred vision. Here you can see combined SLO-OCT of a patient with macular pucker. I would like to suggest that we get away from the term ERM because these are premacular membranes, not epiretinal membranes. And furthermore, ERM has been used to describe the disease. It's actually just a structure, a membrane in front of the macula. And we should use the term macular pucker for the disease that results from the inward tangential traction of this membrane. The Beaver Dam eye study found a prevalence of almost 11%, and the Blue Mountains study found 7% in the general population and 11.6% in people aged 70 to 79. The annual incidence in the Blue Mountains eye study was 1.1%, which means in the United States there are 3 million new cases per year. That's not an insignificant number. We found, employing coronal en face imaging of the vitreoretinal interface, that there can be up to 4 different retinal contraction centers. And there's clinical significance to this because individuals who have 3 and 4 retinal contraction centers have a thicker macula with a higher incidence of intraretinal cystoid spaces than individuals with only 1 or 2 contraction centers. We employ three-dimensional threshold Amsler grid testing to quantify the degree of distortion. So it's not just mild, moderate, or severe, but we can actually get numbers represented as the percent volume lost of the hill of vision. The patient is asked to trace the area of distortions on a computer screen, and they're given 5 different contrast levels of the grid and the background. So on this plane and this plane, you can see the area that the patient drew. And on the z-axis, it's the various contrast levels. And when you stack them in this way, you can get a volumetric representation of the degree of distortions that the patient is experiencing. We have employed this to identify individuals with clinically significant macular pucker and subject them to vitrectomy with membrane peel. And there's nothing exotic about this. The point that is being made here is that no chromodissection is required. You don't really need dyes to identify the membrane in a patient with macular pucker because they're typically thicker. And they're thicker because the plane of cleavage of the posterior vitreous cortex is anterior to the hyalocytes, so that it's about 75 to 100 microns thick to begin with. Then there's migration of glial cells, probably along the retinal vasculature inward towards the central macula, resulting in further cellularity and further thickening of this membrane, and it isn't really necessary to use any dyes to get a hold of this membrane and peel it, as you see here. The lower retina has already been peeled. This is the foveal region here, and with careful manipulation you can peel it off the central macula with very good effects. And we employed three-dimensional threshold Amsler grid testing to quantify the response to therapy, and you can see here that this particular patient went from 2.24% volume loss to 1.3% and ultimately 0.6% volume loss. So this gives us the ability to evaluate various therapeutic approaches, in this case with vitrectomy. And we recently published our results of three-dimensional threshold Amsler grid testing in patients with macular pucker, where their preoperative levels showed significant amounts of distortions as compared to their normal fellow eye. At 1 month, it was reduced. At 3 months, it was reduced even further. And by 6 months, it reached a steady state. But between the 3 and 6 month point, there was significant improvement in the degree of distortions as measured with three-dimensional threshold Amsler grid testing. We found the same thing for contrast sensitivity, not as dramatic, but it is valuable to measure both the degree of distortions as well as the contrast sensitivity function to assess the impact of these pathologies on the macula and their response to therapy. Macular hole is another manifestation of anomalous PVD with vitreoschisis. In this case, the split occurs posterior to the level of the hyalocytes, so somewhere around 50 to 75 microns anterior to the retina. The hyalocytes leave with the rest of the posterior vitreous during PVD, leaving a very thin membrane that's attached to the macula, but also to the optic disc in patients with a macular hole. A cuff is seen surrounding the macular hole, and that cuff represents most often cysts surrounding the macular hole as seen here. Once again, the vector of force exerted by this membrane on the macula is outward or centrifugal, opening a dehiscence in the central macula. The gas classification is demonstrated here, where there's persistent adhesion of vitreous to the macula, usually at the edge of the macular hole in stage 3. But in stage 4, there's been a PVD, but there's still a membrane attached to the macula, and the origin of that membrane is, in many cases, perhaps not all, but in many cases, the outer layer of the posterior vitreous cortex that has experienced vitreoschisis. There's a new classification that was proposed in 2013 to better characterize vitreomaculopathies, in particular macular hole. I don't want to go into the details, but I do recommend you analyzing this and using it in assessing your patients. Macular hole surgery is performed with chromodissection. It's the use of dyes to facilitate identification, but also, in the case of certain dyes, to alter the characteristics, the biophysical characteristics of the membrane that was left adherent to the macula. And the objective here is to remove the gel vitreous and then stain it, in this case with doubly diluted indocyanine green dye, to facilitate elevation of the membrane off the retina. I have always begun my dissections along the temporal, usually the inferotemporal arcade, because of the ability to engage far from the central macula. I know that's in stark contrast to Steve Charles, but I feel more comfortable. And I also think that it's a more natural cleavage plane that is achieved once you start to peel at the inferotemporal arcade and elevate a membrane off the retinal surface. So here you can see the membrane is coming up. And again, the moment of truth in this surgery is when the membrane is peeled across the central macula and you see it releasing from the edge of the macular hole. That needs to occur in order for the traction upon the central macula to be relieved and for this patient to do very well. The use of gas has recently come under reevaluation, and there are increasing numbers of people who don't use gas following macular hole surgery. I'd like to hear from my co-speakers what their practice is at the present time. Yesterday's symposium discussed the inverted flap technique for macular hole surgery, so I'm not going to go into detail here. Simply, the difference between macular pucker surgery and macular hole surgery derives from a better understanding of their pathophysiology and the constituent cells and tissues in the pathologic membrane that result in the different approaches. And here you can see the membrane is being pulled off the edges of the macular hole, achieving the following result. At 2 weeks, there was elevation of the central macula, something that I'm sure many of you have seen. The visual acuity was 20/50. At 2 months, there was flattening of the central macula with improved visual acuity to 20/25. A new form of therapy for patients with macular hole is non-surgical. It's pharmacologic vitreolysis, which is a drug therapy to alter the molecular structure of the vitreous body and the vitreoretinal interface. And originally, it was proposed as a way of enhancing or facilitating surgery. It has subsequently been found to be effective in replacing surgery, but one day it may well be that drugs are used to create a posterior vitreous detachment prior to the onset of disease in order to prevent it. Ocriplasmin was successful in 27.1% of cases when they considered all comers. But if you have an individual whose extent of vitreomacular adhesion is less than 1,500 microns and there's no evidence of a premacular membrane with pucker, a patient who is phakic and who is less than 65 years old and who is a woman, the likelihood of success increases to 68.4%, and this was based on the data of the clinical trials. Here's an individual who's a 62-year-old phakic woman who had poor vision and distortions with visual acuity of 2200, and this degree of abnormality on three-dimensional threshold Amsler grid testing. 28 days after injection, the vision improved to 20/40, and whereas pre-injection, the macula was elevated with a membranous attachment to the edge of the optic disc and to the edge of the macular hole. 1 month post-injection, you can see this normal indented fovea, and the volume decreased. By 15 months, it decreased to 0.15 microliters. And although there was the similar elevation that we saw following surgery for macular hole, it eventually resolved. In this case, it took 15 months. That's pretty unusual. It usually resolves within a few months after vitrectomy surgery. And here you can see the serial three-dimensional Amsler grid improvements from before surgery out to 6 months, where there's been a reduction in the central abnormality. And it's very useful to have numbers that correlate with the improvement, not just that the visual acuity improved from 2200 to 2020, but that the degree of distortions improved. And so these are the reasons that this individual succeeded. The chances were 2/3 that she would respond to this therapy. The last topic that I'm going to be discussing is what happens if you have a posterior vitreous detachment that does indeed separate away from the retina without damaging the retina. Well, it turns out that even an innocuous PVD can induce visual disturbances known as floaters. And here you can see a photograph of a Weiss ring. This is the ring that represents the attachment of the vitreous surrounding the edge of the optic disc, which is visible after the posterior vitreous separates away from the posterior pole. This can be detected by ultrasonography. This is the posterior vitreous cortex with the Weiss ring within it, and here's just a Weiss ring anterior to the optic disc. Many patients complain of the shadows that are created by this Weiss ring. The other thing that they complain about is the interference of the transmission of light by the posterior vitreous cortex, which is now separated away from the retina and is floating in front of the retina with ocular saccades and with head movement. Indeed, PVD is the most common cause of floaters that bring patients to many of our offices. But the question is whether floaters are a nuisance or a disease. I was taught, and I have taught, that posterior vitreous detachment or myopic vitreopathy inducing vitreous floaters is nothing more than a nuisance. But that isn't the experience of our patients. Indeed, studies have shown that they feel that the negative impact of vitreous floaters is equal to AMD and greater than glaucoma and diabetic retinopathy. Patients feel that vitreous floaters are equivalent to angina, stroke, colon cancer, and asymptomatic AIDS. They are so bothered by their vitreous floaters that they would be willing to accept a 7% risk of blindness, and they would be willing to exchange 1 out of every 10 years of remaining life just to be rid of their vitreous floaters. And this has been validated by other studies, and the high frequency of vitreous floaters out in the general population has been identified using a smartphone survey to be something on the order of 3 out of 4 people have floaters, and 1 out of 3 feel that they're impaired by their vitreous floaters. But doctors still consider floaters just a nuisance. Why is that? I believe it's because of the absence of clinical indices of structural and functional abnormalities with which to define vitreous floaters as a disease. And this hampers doctors' acceptance of vitreous floaters as a disease. So we've spent the last several years trying to develop quantitative, objective clinical indices with which to characterize the severity of vitreous floaters and their impact on vision and well-being. And we began by measuring contrast sensitivity function. It was the suggestion of the ever-brilliant Alfredo Sedun that we try to measure contrast sensitivity in these individuals, a suggestion that I initially poo-pooed, but due to my utmost respect for Alfredo, we decided to look, and in fact, he was right. We use the Freiburg Acuity contrast test developed at the University of Freiburg as a web-based test that's available to all for free. And the Weber index is the result of this test. The lower the Weber index, the better the contrast sensitivity. The higher the Weber index, the worse the contrast sensitivity function. And in a series of 96 patients with clinically significant vitreous floaters, we found that the average contrast sensitivity was 4.53% Weber at 5 cycles per degree, as compared to 32 age-matched controls who had a contrast sensitivity at 2.4% Weber at 5 cycles per degree. And again, the lower the Weber index, the better the contrast sensitivity. This represented an 89% worsening with highly significant statistics in a patient population complaining of floaters. We did another study looking prospectively at the impact of posterior vitreous detachment on contrast sensitivity function, and found that in a series of patients with normal contrast sensitivity who then developed a posterior vitreous detachment, there was 54% worsening of their contrast sensitivity following PVD. Once a vitrectomy was performed on these individuals, every single one normalized. We've also developed quantitative ultrasonography to provide a structural correlate of this functional deficit in patients with vitreous floaters. Because I've shared the same experience that you all have, it's very hard to figure out whether an individual sitting before you complaining of vitreous floaters is just overreacting or whether they have a clinically significant malady. And so we employ quantitative ultrasound to get a structural index of the severity of change within their vitreous. This is particularly useful in young myopic individuals. We've developed limited vitrectomy to treat these vitreous floaters. That is a 25-gauge vitrectomy where no posterior vitreous detachment is induced and 3 to 4 millimeters of vitreous remain intact behind the lens. And the various physiologic considerations that Einar alluded to were part of the reason, but also the induction of a PVD in an individual who doesn't have a PVD carries with it a 25 to 30% risk of iatrogenic retinal tears. I've performed this operation in 151 eyes of 121 individuals, and you can see their demographics here. Notably, 96 of these individuals were phakic. The etiology of the vitreous floaters was PVD in 2/3 and myopic vitreopathy in 1/3. Here you can see the effect of limited vitrectomy on contrast sensitivity function. These are the control eyes. These are the 96 individuals who have clinically bothersome vitreous floaters. Their contrast sensitivity was significantly worse than the individuals who had no symptoms resulting. Within 1 week of surgery, every one of these 96 individuals had normalization of their contrast sensitivity, and it's been sustained at 1 month, 3 months, 6, 12, 24, 36, and we have some individuals that we've followed for more than 4 years who've maintained normal contrast sensitivity function. In these 151 eyes, there were very few complications. The mean follow-up is on the order of 3 years. 115 were followed for more than 1 year, 79 for 2 years, 55 for 3 years, and 38 individuals for more than 4 years. There were no cases of endophthalmitis, no IOP problems. 6 individuals experienced a vitreous hemorrhage immediately after surgery, but it cleared spontaneously in every case, did not require any surgery, and the patients were very happy long term. Macular edema of the cystoid variety occurred in 1 individual, and 1 individual with diabetic retinopathy had aggravation of diabetic macular edema following the surgery. A retinal break occurred in one 32-year-old myopic individual. It was identified 3 weeks following surgery and treated prophylactically with no untoward sequelae. Retinal detachment developed in 2 individuals. 1 occurred 2 weeks after surgery, so I do think it was related either on an iatrogenic retinal tear or a retinal tear existed prior to surgery that went undiagnosed. Each of these patients, the second patient occurred 14 months following the floater vitrectomy, and it's arguable whether it's related, but I share it with you for full transparency. Each of these individuals had surgery, very good outcome, and are very happy. Retinal artery occlusions occurred in 2 individuals. They were in their 70s with systemic hypertension, elderly gentlemen, and there have been several consultants looking at the case, and none have felt that surgery was related, but unfortunately, we could never convince the patients of this. Cataract surgery occurred in 16 out of 48 individuals who had a 24-month follow-up. The mean age of these individuals was 64, and no patients under the age of 53 required cataract surgery. We recently published our results in a head-to-head comparison with those at the University of Amsterdam, where an extensive vitrectomy is performed, inducing a PVD and removing as much vitreous as possible, in comparison to our technique, where a PVD is not induced, thereby lowering PO2 levels in the vitreous body. And 3 to 4 millimeters of vitreous is left intact behind the lens because it contains antioxidants, as were alluded to earlier, in an attempt to mitigate against cataract formation. And what you can see is that at 24 months, the incidence of cataract surgery was approximately 80% following extensive vitrectomy, whereas following limited vitrectomy, it was approximately 30%. Furthermore, the mean time that it took to get cataract surgery following the floater vitrectomy was on the order of 7 months following extensive vitrectomy and 12.6 months following limited vitrectomy. So I think that the physiologic considerations that we discussed earlier are very relevant, and that there are ways to modify the vitrectomy procedure so as to mitigate against cataract surgery. So in conclusion, vitreous floaters have a significant negative impact on the quality of life, primarily by reducing contrast sensitivity function. Measuring contrast sensitivity and employing quantitative ultrasound to evaluate the structure of the vitreous body, as well as getting visual function questionnaires to assess the impact on quality of life, are useful clinical metrics for case selection. Limited vitrectomy is effective by normalizing contrast sensitivity, and it improves well-being. Indeed, the complications are very few, making this procedure safe, and indeed safe enough if we're to fulfill the mission of modern medicine, which should be to help people die young as late in life as possible. Thank you very much. I'd be happy to entertain any questions that there may be. Yes, please.
Hi, Beata Falkenberg from Bern, Switzerland. I have a question. You told us that the patient were suffering from these floaters, and you put it equal to AIDS and colon carcinoma. So in our daily work, we don't have so much time to explain to the patient. So my question is, what is the best piece of advice, due to this short time that we have, what is the first thing that you would tell the patient?
The first thing I tell the patient is that they're not going to go blind, that this is not a progressive disease, and that what they experience now is probably as bad as it's ever going to be, and to give it time. The average time of coping in our patient population was 3 years. These are not people who walk in and complain of floaters and get signed up for a vitrectomy on Monday. We ask them to adjust, we ask them to cope. I like to know the people better because, as you can relate to, there's a certain personality of the individuals who seek our attention for vitreous floaters. So you have to be careful. And I think that time sorts out a lot of these issues. The second thing I tell them is that laser treatments are available, but there's absolutely no scientific evidence that they work. I don't perform YAG laser treatments for vitreous floaters. I don't know whether my colleagues do or not. But in the absence of objective quantified measures of structure and function showing that there is efficacy, I don't think it's legitimate to recommend this treatment. I think there's a very major placebo effect in that. But I recommend caution. I recommend waiting. You lose absolutely nothing by waiting, and it works quite well. Pepe?
I think that there is a population with high demanding of floaters, which is myopic patients. Myopic patients sometimes have some cataract and the floaters, and the problem is that this patient is operated only of cataract. After the surgery, sees much more the floaters. I think in those patients, probably will be benefit to perform the combined surgery, cataract and limited vitrectomy, as you have said.
Well, that would be very doable in a European setting where combined vitrectomy and cataract surgery is quite routine. The interesting information is that 1/3 of our patients did not have a posterior vitreous detachment, only had myopic vitreopathy. They tended to be in their 20s and 30s. These are 20/20 eyes in a young individual, and I have operated on them with some degree of trepidation, but my experience so far is that none of them develop cataracts, and we're now at 5 and 6 years, and they are extremely happy. And if they were to develop cataracts at 5, 6, 7 years post-op, they wouldn't complain about that at all. So your point about myopic vitreopathy is a very good one, and I think that it's a very reasonable approach, especially in a European care setting, to do both cataract surgery and limited vitrectomy simultaneously. Yes?
Sorry for going back to a very general question, but as you are one of the greatest experts on the topic, let me ask you, what is your indication for epimacular membrane surgery? So how do you decide on surgery?
When a patient has a premacular membrane inducing a macular pucker, is that the clinical circumstance?
Yes, it is.
If their distortions are clinically significant, and I have the ability, thanks to Alfredo Sadun, to be able to quantify with three-dimensional threshold Amsler grid testing their degree of distortions. That plus decreased visual acuity, I don't like operating on many 20/20, 20/25 eyes, so typically my patients will have 20/40, 20/50, 20/60 visual acuity and demonstrable distortions that can be measured on threshold Amsler grid testing. The anatomic considerations of macular thickening or the degree of corrugation or effacement of the fovea are less important to me. Their function is more important. And in fact, I find it somewhat frustrating in individuals with macular pucker to do a perfect procedure, but they never get back their fovea in some instances. And I don't know what's different about those individuals from the ones who have restoration of good foveal anatomy. Functionally, they get better, their acuity improves, their distortions diminish, and we can measure that postoperatively with three-dimensional threshold Amsler grid testing. But I use the functional criteria more than the anatomic criteria to select patients for vitrectomy with membrane peel.